This left knee AP view and lateral view shows arthritic changes with joint space narrowing, which is symmetrical, more towards medial than lateral. There are osteophytes, there is osteopenia, and there is involvement of patellofemoral joint. With these findings, it is a case of tricompartmental arthritic changes, which is most consistent with inflammatory arthritis, such as rheumatoid arthritis. I would like to take a pertinent history of the patient with important consideration for the pain, hampered daily activities, and stiffness. Understanding the fact that radiographic changes are sometimes not consistent with patient symptoms. The history should also include patient previous medical treatment specific to the knee and for the underlying arthritis. Patient can be on medications which I need to consider before offering any treatment. I would also consider for involvement of other joints and other comorbidities. First and foremost, if conservative treatment should be offered, which can be analgesia, braces, strapping, orthotics, or change in lifestyle. Addition of a stick or a cane sometimes benefits quite effectively. Regarding the implant, I would like to have a complete all the radiographic images and clinical examination. X-rays such as weight-bearing standing views and scanogram, including skyline view for the patellofemoral joint, should be considered. Templating is always beneficial. Type of implant I would consider is a posterior stabilized knee, noting the fact that the case would have already been involving PCL and balancing would be very difficult. If instability is in the coronal plane, I will also consider to have a constrained prosthesis in my armamentarium. Regarding the complications, pre-op I need to consider examination of cervical spine, which can be involved with atlanto-occipital or subaxial spine. Medications like methotrexate, infliximab or rituximab or anakinra, these need to be considered. Methotrexate can be continued, while the biological modifiers should be one half-life stopped, so 1 week for example for infliximab. Anesthesia issues should be considered and cervical spine should be safeguarded. Other joint involvement should be considered. Regarding the operative, skin issues can happen. These people can have psoriasis or thin skin because of use of steroids. Bleeding is common, so we should have already prepared blood for the patient, or autologous transfusion should be considered. Infection risk is higher with biological modifiers. Periprosthetic fractures are more common operatively. Regarding the post-operative, infection and peroneal nerve palsies and other complications such as DVT are more common. In these rheumatoid arthritis patients, the implant, like a total knee implant, would have less complications if done effectively than arthritic patients, because arthritic patients are more mobile and more active. Study with peroneal nerve palsy has shown that if the valgus is more than 12 degrees, there is a higher risk of having peroneal nerve palsy. Regarding the treatment, I will remove the dressing, do a flexion of the knee, and would consider conservative treatment for 3 months. After 3 months, at the time of 3 months, I would consider to have EMGs and nerve conduction studies. Regarding how many patients would have been would have normal common peroneal nerve symptoms, about 1/3 would be normal. Other 2/3 would have some issues remaining after a conservative management for a year even.